Professor Sinjab, welcome to my podcast. Such an honor to have you here.
It's a great pleasure, actually. Thank you very much.
Thank you. I would be happy to talk about your current project, which you're working on. It's a SARSA, Sinjab Academy Refractive Surgery Advisor. And before we start talking about that, I would like to know your opinion about the role of artificial intelligence in medicine and particularly in ophthalmology.
First of all, thank you very much for inviting me to your prestigious platform. It's a great honor and pleasure to me to be on this very informative platform. Now, this topic is very good one, and it's a hot topic because nowadays artificial intelligence is getting more and more included and enrolled in ophthalmology. In terms of ophthalmology, the AI has many roles. The first one is, let's say, assisting the fast diagnosis. So we could get like quick diagnosis of a disease, especially if it is complicated and needs to have many information to be collected. The other thing is it gives more accurate diagnosis because as humans, we may miss or let's say we may skip some points during our exam. For example, if we are examining the anterior segment of the eye and the cornea by the slit lamp, sometimes by the fast or a quick examination, we may skip some opacities, we may skip some epithelial pathologies, while for example, if we upload the photo of the cornea to an artificial intelligence software, maybe we will get better diagnosis and more accurate diagnosis. So it will assist for that. The third role is interpretation of imaging and investigations. As we know, we have a lot of investigations like the fluorescein angiography, like the fundus photography, like the tomography, specular microscopy, a lot of imaging. So instead of depending on only a human experience in this, which differs from a surgeon to surgeon, a doctor to doctor, and differs as well based on how many years or the how much depth of this subspecialty. So this interpretation will assist in order to get like a classification and diagnosis based on those investigations. Number 4 is decision planning. We know that after we collect the data, including the examination, investigations, history taking, all of that, we can input all of these things into the software, IA software, which will have a sophisticated mathematical algorithms in order to give us like decision plans based on, let's say, evidence-based and experience of surgeons. In addition, it may give the surgeon alternatives. So it's not only to give one diagnosis and one decision making, it may give alternatives as well, differential diagnosis. So it will be something very interesting as an assistance to the surgeon.
And and this was basically the reason why you decided to start your own Sinjab Academy Refractive Surgery Advisor.
Yes, exactly. The SARSA, exactly.
Yes. And so could you just talk a bit more about the main aim of that? Basically, you already covered why we need artificial intelligence in ophthalmology, but the main reason and purpose of creating SARSA.
Yeah, great. Thank you very much. Actually, as you know, it is Sinjab Academy Refractive Surgery Advisor. So it is an advisor, just to give some, let's say, kind of advice, to give some recommendations to the surgeons, to be aware of warning signs, some calculations. So the main aim, let's say, is assisting refractive surgeons to validate the tomography captures, then to interpret the tomography captures and their 4 systems are included, like the Pentacam, the Galilei, the Cyrus, and the MS-39. So each one has its own interpretation. So it will, according to the tomography, it will tell the surgeon whether the tomography capture is valid or not, should be repeated or not. And the other thing is to say, according to tomography, the case is good for LASIK or not, for SMILE, for surface ablation, and so on. The third one is decision making. How decision making? Let's say it makes sophisticated calculations for laser-based options and for lens-based options. We know the laser-based options are the surface ablation, the LASIK, and the femtosmile, and each one of those options has its own criteria, parameters, calculations, safety calculations, and let's say recommendations in terms, for example, diameter of the flap, position of the hinge, amount of ablation, cyclotorsion compensation, decentration to compensate for angle kappa, and so on. And the other side is the lens-based refractive surgery, consisting of the phakic IOL implantation and the clear lens extraction. So it gives recommendations and calculations. For example, the phakic IOL sizing, it gives what would be the diameter, the ideal diameter of the phakic IOL to be implanted in order to avoid touching the crystalline lens and cataract, of course, and avoid the pupillary block and therefore glaucoma, to maintain an average volt. So this is an overview, but much more calculations are included there.
So I checked also, of course, the website, and there is a validation part, and then it comes the PS3 part. I would like to talk about this PS3 algorithm, which is, I understood, based not solely on your experience, but also from the experience of other doctors. And could you please talk now about the principle and concept of PS3 and what the PS3 stands for?
Yeah, actually, the PS3, it's an abbreviation of Practical Subjective Scoring System. So the last 3 words of the phrase, they start with the SSS, Practical Subjective Scoring System. This is why S3 instead of PSSS. Now, it is an algorithm based on evidence. So let me explain it very simply. Each item of the PS3 is based on cutoff values, based on studies, published studies, and references that I can provide to everybody. Now, but those cutoff values and parameters were not gathered in one system. For example, Kmax or Km average, or thinnest location, or let's say the elevations on the anterior surface or posterior surface. So, and other parameters, each one has its own cutoff values. Okay, now, if I have a tomography with, for example, everything is within the cutoff values, but 1 or 2 cutoff values or 1 or 2 values are more than the cutoff values. Should I go for refractive surgery or not? There was no answer before the PS3. Okay, so evidence-based of the parameters has been there for long years, for example, but now it's time to collect those evidence-based parameters and cutoff values and put them in one system and give recommendation to the surgeon that, look, if you have, for example, these 2 parameters are above the cutoff values, then avoid, for example, refractive surgery. If you have only this one, for example, then you can do surface ablation or SMILE. If you have this and that together, then yeah, you can just say this one is normal and this one is abnormal, so you can do this and that. So the collection of those parameters all together, putting them, are based on my experience. This is the only thing which is based on my experience. Otherwise, all parameters are evidence-based. The cutoff values are evidence-based. And now, based on my experience, does not mean that it is evidence-based that the PS3 will completely avoid ectasia, or not following it will definitely lead to ectasia. It is just like I'm throwing a light on the road, how to use those parameters in a way based on my experience. Now, of course, we need in the future. This is why one of the aims of the SARSA in the future, we can, by collecting data from the surgeons that they are going to use the SARSA and knowing their feedback, pre-operative and post-operative, we can validate the PS3. We can say, yes, PS3 has very high sensitivity and very high specificity, for example, and the percentage of that. So this can be done later in the future when, for example, SARSA 2 comes, after we collect many data from the users. But for now, it is just like a guideline how to use those evidence-based parameters and put them all together.
So as I understand, even though you're taking the information or data from other surgeons, the validation goes through your experience. It's like based on your experience.
Yeah, based on the PS3. After I put this one and we build the software based on that. So the software will give the recommendation to the surgeon, like, look, surgeon, or a message. PS3 says, based on what you input, it's better to avoid LASIK, for example. It's better to avoid this thing or that thing. So yes, based on the PS3, which is my experience in putting all the parameters, the evidence-based parameters, in a way of thinking.
So which factor you take into consideration before you include the data from other surgeons?
Very good question. Actually, depending on just data input from the surgeons, we may get some bias, we may get some, let's say, inaccuracy. I will give an example. Now, if there is a patient and this patient has severe dry eye, and the surgeon did not pay attention to the severe dry eye and decided to take a tomography capture, then after taking the tomography capture, there was some parameters which are out of range or which are abnormal. Now here, of course, we cannot guess that the patient has, let's say, a severe dry eye. And those data that were input in the SARSA are not valid and not accurate, because the dry eye was not treated properly before taking the captures. So we are trying to do two things for the SARSA 2. The first one is to tell the surgeon that first, try to exclude factors of false findings, and a message will appear to the surgeon when they start using the SARSA. For example, did the patient take off the contact lenses for sufficient period of time? Was the surface treated properly? Is there any misalignment during taking the capture, for example, and so on? In order to be sure that we are going to get valid and accurate data from the surgeon, we are going to do two things. First of all, we are going to depend on surgeons that we let's say we are sure that they are doing the workshop properly and they take care of all the details, like treating the ocular surface first, giving a sufficient time to remove the contact lenses, and so and so. This is number one. The second point is to try to notify the user that there might be some factors causing these abnormalities, and displaying those factors affecting the or causing false positives and false negatives. So as a first step, we may allow only for example, 10 or 20 surgeons that I trust with their workup, and then we can make it popular after we build that system that can validate the input from the surgeons.
For the software to make a critical approach by giving the result for a particular case, should we add positive and negative data as well while creating the software? And I would now open what I mean for positive and negative data. So positive data, when we have, for example, a patient A who had -2 myopia refraction preoperatively, underwent LASIK surgery, had a successful outcome, and for the next 10 years, his refraction is perfect, and the outcomes are successful. So this is a positive data. And by negative data, I mean, for example, a patient B, or we can also say patient C, a patient B who underwent LASIK surgery for high myopia and astigmatism and had maybe a bit critical tomography map pre-surgically. And after the surgery, he 5 years later maybe ended up with undercorrection. And patient C, for example, with some similar refraction, but normal tomography, after a few years ended up with keratoectasia. So do we classify this kind of data while putting into the software in order to have a critical estimation of the software for particular cases which we're going to add and get an advice from? And if yes, what is the classification? I mean, what is the percentage and what is the classification as well? If you do these kind of classifications like A, B, C, D, or maybe more.
Yeah, actually, this is an amazing question, and you have just hit the core of the SARSA, or the main aim of the SARSA. We are talking now actually about the machine learning. Now, how we can activate the machine learning in the SARSA? We activate the machine learning by collecting data and results, as you mentioned, as you gave some examples. So we must include the positive results and the negative results. And the negative results are even more important than positive results, because by the negative results, we can adjust the parameters. We can modify the PS3, and we can modify the decision making. Of course, there will be through the machine learning, there will be sophisticated calculations like relation and correlation, as this is the language of the machine learning, based on the feedback, positive feedback and negative feedback. So we need to know the cases that developed ectasia. We need to know the cases that had residual refractive error. We need to know the cases with regression in the future, and we need to know the cases that got wonderful results and remain stable throughout the 10 or 15 years even. So yes, of course. And after that, the machine learning itself will do the calculation and will calculate for us the sensitivity, specificity, and will give recommendations to adjust the parameters in order to get the highest sensitivity and highest specificity.
Is there a function, for example, if based on the age, the software will say, for example, the patient is about 40 or 40 a bit plus, and he has a high myopia, and is there a function where the software says the target of refraction would be to keep the patient a bit undercorrected for his neutralization, his presbyopia or something like that? This kind of or the calculation when the software says, okay, you add the patient, and here instead of ablation surface surgery, I would advise the intraocular lens implantation, for example.
Yeah, actually, we take the age into consideration for the decision making, of course, and the recommendations given to the surgeon and the SARSA. Yeah.
Yes, my next question, is there any control of machine learning? Because you mentioned before the machine learning process. So is there any control of machine learning process, which is basically based on the data collection and creating mathematically algorithms and patterns? But in medicine, not everything is about the mathematical patterns and algorithms. Is there some third part, or I don't know, a surgeon or you who controls this machine learning process?
Yeah, very good question. For now, this first version of SARSA, still we did not include the machine learning because now it is just an advisor, just to give recommendations. But in SARSA 2, machine learning will be there. By collecting the data and by management and the treatment of the data, the machine learning and the AI will give us a lot of suggestions what to do. I cannot tell you now whether there will be any control or not because I'm not specialized in AE, but of course my team who has programmed the SARSA can give us a better answer in the future when SARSA 2 comes.
But I believe that you are the main controller there because IT world, they work, I think, in a better way when they collaborate with doctors and the doctors say what exactly should be
Yeah, I agree
done.
with you. Of course, I'm trying to stay away from any human effect and from any,
Mm-hmm.
let's say, bias.
Mm-hmm.
So, let's say if the artificial intelligence will say, for example, I don't know, but I'm giving an example. There are two ways. The first one is it is purely AI without any influence of human choices or options, and the other, but it will give us, for example, this percentage of sensitivity and specificity. While the other way, you can put your choices and your, let's say, your directions, and accordingly, we will get the highest sensitivity and specificity. Yes, of course, I'm going to select the second way in order to make it better. But
Yeah.
whenever it is neutral, I will leave the AI do its job without any influence.
Mm-hmm. And the last question is the future for SARSA. I know that now it's basically oriented for corneal refractive surgeries, but you are starting already applying this for intraocular lens implantations as well. So could you talk about that a bit? So the question is if SARSA is going to also advise which exactly lens makes sense in this particular case to implant and how
Yeah,
it's going to be
yeah, very good
defined.
question. Very good question. Thank you very much. Actually, SARSA 2 will, let's say, go into more details about the clear lens extraction and the
Mm-hmm.
let's say, premium lenses implantation and types based on the defocus curve, based on the profession, patient's demands. Of course, we have plenty of IOLs in the market, so there will be like better choice for the surgeon that this type is better for this patient. And we are trying to classify the types not based on the brand names, but based on their
Mm-hmm.
functions, okay, the function itself, the defocus curve itself. So this is one point. The other one is to read the tomography by AI rather than letting the doctor input all of these parameters. So we will try to minimize the input from the surgeon. Just maybe it will be like mobile friendly. So it's an application.
Mm-hmm.
The surgeon will just open the application, will take a photo of the tomography, clear photo of the tomography. Immediately, the AI will give the let's say, the advice based on the parameters read from those tomography. So reading the tomography
Wow.
by AE. So this is the second point. The third point is the machine learning. As we mentioned, we are going to try to modify the parameters based on the data collected in order to increase the sensitivity and specificity.
So I'm sure that you have so many young people and so many young doctors working around you. So what would
Thank
you
you.
advise the young doctors who are just also wants to do something but don't have a proper environment around them? And what would you advise them? Because at
Very
the
good
moment
question.
everything is so online, and actually a lot of possibilities to be connected and make also projects. And you having such a great vision and big vision in all these things, what would you have to advise young people?
Very good question. Actually, when I compare the young ophthalmologist nowadays with when I was young, let's say 30 years ago, I say how lucky they are now, because
Yes.
at, at those days we did not have internet, we did not have that huge amount of online conferences, meetings, webinars, and huge amount of resources on the on the website. YouTube, for example, iTube, the surgeries. All what we had that time was just like textbooks, maybe. We may attend at only the local conferences, and attending an international conference was just a dream for us. Nowadays, while we are sitting, while we are taking a cup of coffee at home, we can watch whatever we like. Virtual meetings, YouTube videos, surgical videos. We can learn, we can teach, we can discuss cases. There is accessibility to mentors, to let's say experts, to ask them. I'm talking, I mean, from the point of view of the young ophthalmologist. So my advice is to take this opportunity to discuss cases, to be in groups. For example, the Sinjab Academy group on the Telegram has more than 2,400 participants and
Yes.
or members, and there are a lot of discussions. Sometimes I participate in, sometimes I do not. I do not need to participate because now I have expert surgeons there in the group itself, discussing with other members. So when I look at those discussions, I feel very happy because I could build a platform that will help the seniors, will help the juniors. So for the young ophthalmologist, you have to exert all efforts in order to learn, and all resources are there now. So you don't need to travel to attend a conference. Even the ESCRS or the ASCRS or the American Academy, you can just register and you can watch all the sessions online, maybe simultaneously or maybe later or when they are recorded. So everything is very easy. So no excuse for any young ophthalmologist that I have no way to learn, even in remote countries or remote areas.
I think we covered everything what we planned. Maybe you want to add something, I don't know.
Of course, at the end of this wonderful session, I would like to thank you again for
Thank
inviting
you.
me. This is a great platform. I would advise every young ophthalmologist as well, or senior ophthalmologist, to follow your platform because you
Thank
are
you so
doing
much.
a great job. I always encourage all people like you who have the spirit of doing such scientific activities. I try my best as well to market them. Let's say it is not a market, while it is like to let
Promote.
everybody aware, promote. Yeah, sorry for the
Thank
market.
you so much for everything.